Hamster Wheel Publishing, this is Blunt Dissection. I'm Dave Nichol. On the podcast today, we talk with Dr. Sue Ettinger, aka the Cancer Vet. Dr. Sue is a boarded oncologist and heads up the Oncology Department at the Animal Specialty and Emergency Center in the Hudson Valley, New York. She's a co-author of best-selling Dog Cancer Survival Guide, co-hosts the Pet Cancer Vet podcast, and if that wasn't enough, she's also a Certified Veterinary Journalist, contributing to Clinician's Brief, Today's Veterinary Practice, Veterinary Team Brief, and DVM 360. Dr. Sue is super passionate about raising cancer awareness and developed the awesome See Something, Do Something, Why Wait, Aspirate program. More on that in the episode. This might be my favourite episode yet. The energy was insane. So without further ado, may I present Dr. Sue Ettinger. Dr. Sue Ettinger, welcome to the podcast. It's very, very nice to have you here.
Thanking you for having me.
This is exciting.
Very brave of you.
Very brave of me. Well, in our email exchanges, I'm worried because the podcasts are longer than maybe other people are doing, and then you said you were very chatty, and I thought, because we're both probably of that ilk. So we've got to try and keep this. This could be like a 4 or 5 hour podcast. It can't be because Dr. Sue, we're both sat here at the CVC convention in Virginia Beach. The sun, to set the scene, is blisteringly hot outside.
It is.
I've been running on the beach. I've been fortunate enough to swim near dolphins of all things, which was an amazing start to the day, and the conference is set and it looks like it's going to be a really good conference. I'm particularly excited to talk to you, Sue. We were made aware of each other, I think, by our mutual friend, Andy Rourke, who seems to be a connecting dot for many people around the industry. And so I'm super, well, actually, when I first heard about you, the first thought that pops into my head was you've got kind of a famous second name. And so being of the generation that learned from the textbooks like Ettinger, my first curiosity was, is there a relationship?
It's funny, there are times when I get, I won't hear that question for a long time. And then recently I was back up at Cornell where I went to vet school for a white coat ceremony. And the question came up over and over. But the answer is yes, we are related, but it's by distant marriage, and it will kind of hurt your brain, but I'll tell you. So when I was in undergrad, I wanted to be a vet since I was a kid. And when I was and everyone would say, are you related? And I wasn't. And then my mom called me. She's like, we're related. I said, what? She's like, I was just on the phone with my mom, with grandma. My maternal grandmother, her cousin remarried Stephen Ettinger's father.
Okay. You're right.
So it's not a blood relation.
It's not. So
it's just a coincidence.
It's a wonderful coincidence at that.
Yeah, it is. It's a good name.
I love it. Well, so you are, I've seen what you do in terms of speaking on video. I've heard such great reports, and certainly the interactions I've had with you and what I've heard from others are that you're one of the people that manages to bridge several sort of, or you're able to. You got your foot in the camp of academia and specialization, of teaching, of being in clinical practice, and of being a great presenter. And that's a sort of unusual skill set to put those things all together. So it's kind of, I was excited to be able to do this interview. So thank you very much for coming on.
Thank you for your kind words.
You're welcome. Let's start. And I guess the first question, what I'm interested in, is just for people that don't know you or not aware of you. I think perhaps the world falls into people that already know Dr. Sue and the ones that are soon going to know Dr. Sue. What were your sort of early influences on your life and career? And let's maybe, you can start wherever you want to start, but maybe if you want to even go pre-vet, like give us the background to how you became a veterinarian.
My parents tell me that when I was in kindergarten that I did this picture that, what do you want to be when you grow up? Me with a dog in the background. Like I've always wanted to be a veterinarian. I was one of those kids that always loved animals, always wanted to be a veterinarian. So that was always my track. Then when I went to undergrad at Tufts University in the Boston area, I was like, pre-vet's a lot of science, and I loved art history, and that was the influence of my French teacher. And I thought, well, maybe I'll be an art history major, still be pre-vet, but do both. But it was so hard with all of the pre-vet requirements. So I decided that would be like my second interest, and I took a lot of art history classes. I did a summer in Florence through, a different university studying art. So I always have that passion for art, but, it's just one of those things, always wanted to be a vet. The oncology part is a separate story. I mean, that was, something I didn't figure out until my internship and one of my big failures, trying to become a specialist.
So if I'm hearing you right, so you're not content with just doing one sort of, and in the UK it'd be like an undergraduate degree. You're running two together. Although any of my friends that did the arts generally did 2 lectures a week, but that's enough to push you over the edge, right? When you're doing a veterinary schedule, and then you did a third sort of trip through university as well. So if you're not already getting the picture that Dr. Sue's quite driven, then that might give us some insight in there. You ended up after graduation, and I'm talking about your veterinary degree. Certainly for listeners who are not aware of the US system, generally you do 2 degrees. You do
correct
what we would call an undergraduate degree. Then you do another, what we would still call an undergraduate degree, but you guys have different names for those things, right?
So it's 4 years of undergrad and then vet school on top of that, which is another 4 years.
Right, okay.
So it's 8 years to get to the vet school.
8 years of vet school and 8 years of debt as well, which is always interesting as well. One of your early positions was at a place that's certainly it's almost a mythical place for us in the UK. Not mythical as in doesn't exist, but as in this sort of fantasy realm of big practice. And when I think of this facility, I think of ER, but for veterinary medicine, and that's the AMC in New York City.
Right.
Tell me more about that role and about the place, and can you again give us an insight into what was like working there was like?
So that was where I got picked, and selected through the match program to do my internship. Wasn't my first choice. I'm from the New York area, but I had never lived in New York, so there was that intimidation of going to live in New York City. But AMC is this 8-story hospital
Is it in Manhattan?
On the Upper East Side of Manhattan, and 30 intern mates. And it was like a movie. On the first day, the head of the intern program told us we were all dumb as rocks. And you're like, but I just graduated vet school. I'm so smart.
I have 2 degrees.
I have 2 degrees. And then you go into clinics and you start seeing patients and you're like, I'm dumb as a rock. But and you worked 80 hours a week. You worked 20 days on and then got 1 day off. Some of your days you did from 7 a.m. till the evening. And then you went what was called the double. And you worked until anywhere from midnight till 3 a.m. And then you got back up and were back at work the next morning. It was just the norm there. There was no questioning. You're like, well, this is what you do. So it was this crazy program. But when I finished, I wasn't dumb as a rock. Thank you, Dr. Garvey. He even told us all. But I felt so comfortable to go and do any ER shift in anything that I had gained so much experience. And it was very teaching oriented. So it wasn't all about work, which is different than some internship programs. But 80 hours a week, it was crazy, but it was so worth it. And I know you probably don't have to work that hard to get that, but it was something that I at least look back and feel like it really trained me well and shaped me in the clinician that I wanted to be. Right.
And that, do you think that's something we're losing now? I mean, if a graduate were to apply for a role there now, would it be the same or has that changed?
It's changed. I'm not there anymore, but I know the internship program is smaller. There's also been a shift, I think, in a lot of these programs to not have we were on our own in the evening with supervised by a resident, but there was 4 interns and a resident. So you're never really alone. But I think there's a shift and I think a lot of it is patient driven and client driven to have more experienced doctors on the ER. So they have less interns there. I don't think someone should have to work that hard and sleep that little to get that. It was very old school. And the other thing, it was tough. If you messed up on a case, you admitted on the ER, they called you over in the morning in front of the group that picked it up. And they told you what you did wrong.
Yeah, right.
Yeah. And, I did go to the locker room a couple of times and cried and think, I'm not going to get through this program.
Yeah.
I'm not tough enough.
And probably everyone in the interns had the same experience, right?
Yeah.
The podcast is a lot about dissecting the anatomy of success. And a lot, you have been very successful, and from our conversations prior to this point, I know that the route to where you are now has not been a straight line.
At all.
My first question, I've got lots of questions about that, but my first question is more about the discipline and the effort and the routines and habits that you employed or deployed in order to become a diplomat, a specialist. Tell me about the journey. And I'm going to come back to because I know that you had, it wasn't a straight line, but I'm more interested in the actions and the focus that was required in order to be a specialist. Certainly some of the audience listening will be people who are starting out their careers, who have ambitions to get to where you are in whatever discipline they want. What's required?
For me, it's crazy hard work. And I can tell you, so my husband was my intern mate. That's where we met. And he's a brilliant guy. And when he studied for boards, he sat 2 years ahead of me. And, you have some time off. And I would literally walk into our study and he'd be in the lazy boy chair, looking at articles, holding them above, looking, just skimming through them. And then I'd come in again, he'd be playing whatever video game was, And for me, when I study and for me to be successful, I have to work so hard. Study, take notes of my notes, toil away. When I studied for boards, it was 12 to 14 hours a day, hunched over a desk.
Yep.
Studying. So for me, I feel the key is hard work. I'm not saying I'm not smart, but I'm also a person who has to work really hard to pass tests and achieve things. It doesn't come to me naturally. I work really hard at what I'm doing. So that has been my underlying thing, is just put my head down, work hard, and try not to perf an ulcer.
And the ulcer moments. What's likely to give Dr. Sue an ulcer?
Bringing me back to my residency days, it was whether or not I would pass boards,
right.
Because there was so much pressure and I didn't want to have to wait a year and do it again and then tell people that I failed.
Yep.
So that was probably one of the biggest. I probably did have an ulcer. I was on, I put myself on over-the-counter anti-ulcer medication at the suggestion of my husband, who was watching me toil away.
Right.
Actually, when I passed boards, he said, "Thank goodness you passed boards, because I don't know how you would have studied harder." Right. He's like, I don't know what you could have done more to pass that test, but it's a bad test.
Okay. And I suppose it has to be in order to maintain the quality. Your first choice, and we're going to talk a lot more about cancer in general, but your first choice when you first set out on your journey wasn't to become an oncologist, was it?
No, I wanted to be a surgeon.
Right.
And actually, if I tell you this, blunt dissection, you might have to kick me off the podcast. You're like, at first, that's not about surgery, right? He knows I'm not a surgeon. No,
it should be sharp dissection for an oncologist, though,
exactly.
shouldn't it?
When I was in vet school, Cornell did not have an oncology program. We learned about cancer, but when you got into clinics rotation, there wasn't a dedicated oncology service. So there wasn't the focus there. When I was a second year, I became friends with a surgery resident. And every year he took one or two students sort of under his wing, and we did the overnight. We were the ones who were on call to set up the OR for the emergency surgeries. And he was so passionate about surgery. And I was like, I'm going to be a surgeon. And who doesn't want to be a surgeon, right? You fix things and you remove things. And I thought it was so cool. So my path was to become a surgeon. And when I graduated Cornell and went to AMC, they ask you, what are you planning on applying for a residency? Surgery. So they try to give you those rotations in the beginning to get you set up for your application for residency. So I had surgery, soft tissue, then oncology. I was like, oncology, that could be fun. Then orthopedics. And I was like, I did my oncology rotation. I was like, this is fun. You know what? I'm going to be a surgery oncology person. I'll do that. I'll do my residency. Then I'll go to Colorado. I'm sure I'll get it. And I'll do, for me, it was like, I just put my mind to it. It will happen. And so I was like, I'll just combine the two. So I went through, did the application, did all the interviews, and then I didn't match for surgery that year. And it gave me great pause. It was also one of my first times I think I really failed academically as a driven person.
Yeah.
But it was one of the best failures in my life because it allowed me to realize I don't think I want to be a surgeon.
Yeah.
And then I had to do a couple extra steps to get into the oncology world because, to be honest, I don't know if you know this, but a lot of the times, whether it's radiology or surgery, they don't like people who switch because then they think, you're just doing it because you didn't get it the first time. So I had to do an oncology fellowship at Duke, and then I went back up to Cornell and did another oncology position, and then I matched for my oncology residency.
To almost show the people
that I really...
That's what you're really into. Take me back to the subject of... Two things popped in my head as you were going there. One was people who you've experienced or encountered who've been very passionate about what they do have clearly had a big influence on you, from your French teacher, or the art history teacher, sorry, to the surgical person. That's coming across in absolute spades here. The people like that fire you up and have really inspired you. The other thing I wanted to just touch on then was how did you deal with and handle that failure, that perceived failure? How did you process that and move forward past that?
And I actually like getting a little bit like just thinking about that moment. So Garvey, who's this very large man who told us we were dumb as rocks on the first day of our internship.
Yeah.
As he was smoking a cigarette, drinking a big thermos of coffee in a room that said no smoking, like it was the conference room, all 30 interns, bright-eyed and bushy-tailed. But this was before you could log in on the internet and find out. Like you waited. And so he walked around the hospital. Of our 30 people in our class, probably almost 20 applied for residencies. Yep. And Huter, my husband, like, Huter, you're staying here for medicine. Bonzinski, you're staying here for surgery. Dan, you're going to, he was going to Tufts for nutrition. He was like, Ettinger, I got nothing for you. Like in front of everybody. Like you just walked around the big hallway and you're like, oh. So not only was it a personal failure, it was that social failure. Like you were in front of all of your peers. It was heartbreaking. And I wasn't the only one who didn't match, but it was a devastating blow personally to experience that.
And what happened next? And thinking your processing of it.
I think...
How did you get to...
I think my initial thought was I'll just apply next year, right? Yep. Fail once. It wasn't like, I didn't want that anyway. But as I was like, well, what should I do? There was, there wasn't specialty internships like we have now in the States. So I started to look into programs that I could do for the next year. Did I want to go into private practice? Did I want to do something surgery related? And then this Duke position came up about, it was a research position down at Duke, and it was a joint program with NC State. I was like, maybe this is going to be the thing I want to spend my next year doing. And then I did that. And then I applied for oncology, failed again. At least I was in my office at Duke, and the only person that knew was my supervisor. She was a radiation oncologist, but it wasn't the and then when I was back at Cornell, I finally matched and I went back to Animal Medical Center to do my medical oncology residency 2 years after finishing my internship.
How did you get reasons for each failure, like the failure to match with the surgery program and then the failure to match with the oncology the first go around? Were you given feedback or reasons on those that could help you move forward? You
don't really. It's a very detached process because, this computer spits out where you're going. You talk to your mentors and they may say, and I applied, I think, for 20 surgery programs. It wasn't like I was limiting myself geographically because I said, I don't want to go there. I applied for private practice. I applied for universities. Some people said your GPA is not high enough. I graduated vet school, I want to say, with like a 3.5, like respectable, not top of my class. But, so some people say it was your GPA, you didn't have a paper, nothing that was...
What does GPA mean? What is that? Is that basically like your level of degree?
Yeah, it's it's like out of 4.
Right.
So in the universities in the States, both undergrad and vet school, it's based on it. So a GPA of 4 is perfect. It's like, is graduating with 100%.
Okay.
So
it'd be our equivalent of having a first class, a 2-2.
Yeah. So I was probably in the top third of my class, which to be a surgeon is, not good enough, kind of thing. So those were the things, like you need to do a paper, you need more experience, things like that. For oncology, it was very simple. This is your first time applying, and we don't believe you. I mean, that was literally the unofficial, people would tell me off the record, it was because I just changed my mind and they didn't believe that that I was passionate about it. And now the funny thing is I look back and I don't even want to biopsy like a mass. I did that for the first couple of years when I was a boarded oncologist, and I was like, this is not my thing. Like, I can't imagine doing anything else. And so my advice for people is, it's hard not to get swept up by someone else's passion, which is what you were saying, right?
Right.
Somebody could be so passionate about it. You're like, oh my God, I want to do what they're doing because look how happy they are. Look how much they love. And I love what I do right now, but I thought I wanted to be a surgeon. So I think, that's the hard part about follow your passion is you might not always know what your passion is at the moment.
And that sort of leads into the next question, which I'm fascinated to being open to the journey. Mm-hmm. And that sounds like a lot of us, this whole concept of success being, I start here, I get there, just as a fallacy that doesn't exist. You get halfway along and then you think, oh, I'll try that, and try something different. And you almost by accident run into the thing that you love. If you could go back in time to the start of that, are there any clues that you could look back and go, I knew then that might have been a smarter way for me to go? Or would there have been any processes that you would tell yourself right back at the start of your career, you should do this, that will help you find your direction?
I don't think so, to be honest. For me, it's the experience, and I think, I look back when I did my oncology my oncology rotation during my internship, and I got really excited about it. To be honest, if I had at that moment had the revelation, apply for oncology, it was sort of too late.
Yep.
Because I had told everybody I wanted to be a surgeon, so I probably wouldn't. So for me, I don't think so. And I look back at those failures and I'm grateful for them. Right. I think they're important for us. And I think it's also really important to talk about it because I look at other people that when I was trying to become an oncologist that seemed so successful and you're like, oh, it was so easy for them. And it wasn't. And I think it's, those really crappy moments when Garvey's walking around and says, Ettinger, I got nothing for you, that make you a better person in the long run.
They do that or they crush you. Is there anything different about you that makes you more resilient to those moments? Or have you found ways to build that as you go through your career? And, I'm going to talk a little later, ask you questions about, the discipline you're in now on the outside looks like it could be a depressing place to work. All of our patients are all going to die at some point, but your patients in particular.
Such the myth.
Right. And so that's a question we'll come on to,
okay.
which is one of the real reasons I'm super fascinated to talk to you about this. But is there anything in those experiences that built your resilience, or were you just more naturally resilient? Can you put your finger on anything?
For me, I feel like it's to get good at anything you practice. And I'm a very sensitive person and I'm a very, as you said, driven person. I don't like to fail. I'm a people pleaser. I don't like to disappoint people. But you're not going to, when I lecture and people say, how do you do aspirates? I'm like, it's all about practicing. My son says to me, Mommy, how do you get so good at speaking? Buddy, I practice just the way I tell you to go out and shoot more baskets, right?
Right.
So not that I want to practice failing, but I do think every time you fail, you probably are going to learn a little bit more. So the next failure, maybe it won't be so gut-wrenching and you can try to look for the things in that failure that you can move forward and be positive about it. Because I think we need to be positive. I'm trying to be a very positive person, but I still don't like to fail,
right.
But it happens. I'm sorry, it does,
Yep.
Whether it's, on a day-to-day interaction with a colleague, or just on a personal level. I think, failure is inevitable, but just learning to not be so hard on yourself, I think is the key.
Reframe it as a learning opportunity as much as anything. Okay, so let's move into probably the area people are most interested in to hear about from you, and that is the whole field of cancer. I mean, it's a big area to tackle. So one of my first questions is, and one of the reasons I think what you're doing is so interesting and exciting. We just touched on it there. This myth that cancer is a death sentence. Expand upon that. Let's start there.
It's funny though, because when I work, at a big hospital and people sit in the waiting room, they're surprised if I made you like look at the waiting room, which are my patients. It's the happy golden wagging his tail. I mean, most cancer patients are happy, healthy patients, except for their cancer, meaning they have very good quality of life. And one of the myths is, I don't want to poison my dog with chemotherapy. I don't want to torture them with therapy for them to feel better after. What I love about treating dogs and cats with cancer is 80% have no side effects of the ones that need chemo. So they have a great quality of life during treatment and after treatment. And one of the hardest things that I have to do is educate people about that so they can make an informed decision. Because treating's not for everybody. Yep. It's not cheap. It's a commitment. You often have to get there weekly or every other week or every 3 weeks. I'm okay if somebody comes in and says, Dr. Sue, this is not for me. Thank you very much. But what frustrates me is when someone comes to see me 3 months later and they said, oh, if only I had seen you earlier, I would have maybe thought about treatment. So it's just really educating people that their dog and their cat's going to have a really good quality of life, not just after treatment, but during treatment.
During it as well. What are the most common and most serious mistakes that vets make when dealing with cancer?
I think assuming that the client won't treat.
Okay.
That's not the medical part of it, but that's a huge part of it. And maybe not working it up as aggressively as they medically know they should, or just not giving the owner options up front. Or saying, oh, I'm not going to submit this aspirate because the owners can't afford it. But if you educate the client why we want to aspirate, they might do it. And I have found that by educating clients and giving them options. So I feel like that's a huge mistake. Or not. I feel that, so many clients have such a trusting relationship that's well earned and well deserved with their primary care veterinarian. And if the primary care veterinarian is pessimistic about treating cancer, it shapes the whole relationship.
So that's a fascinating thing. So, and I don't know, the name that came into my head there was the human MD Deepak Chopra. Mm-hmm. And something I heard about him recently, I know he's a controversial figure and, the mind-body link and, whether or not it's out there in quackery, I don't know. And I don't have a particular opinion on that. But one of the things I heard was, which really made sense to me, was when a doctor tells somebody they've got cancer and they tell them how long they've got to live, more often than not, they're right. And when that number time comes up, there seems to be evidence to suggest there's at very least a correlation between that information and the reality. And that one of the bits of advice that he had given was, by all means, tell them they have cancer, but don't tell them it's a death sentence. Don't put a time limit on that. That seems to resonate, or certainly be echo what you're saying there about the vet's perception then has an impact on how things go for you. What are the extremes of that? Like, can you put numbers on how much of an impact that would have based on what you've seen?
People want numbers, and my husband's internist. He's a board certified internist, and I always turn the table on him. I'm like, but you don't tell people how long their cat's going to live with renal disease. You don't tell people with Cushing's or heart disease. But when people come see the oncologist, how long is my dog going to live, doc? They want numbers. So, but I always tell people I live to be wrong. And I do have cases that live way beyond the survival times. And that on the flip side, there are patients that don't live as long. So I try to get people less clung onto the numbers. Yep. But when I was a resident, we had to know median survival times and response rates and a lot of statistics. And I was trained when I went in the exam room to give people that. And so I try to balance that a little bit more than just coming in and telling people what a number is, because I do think that number can be very devastating and be difficult for the owner to decide what to do if they think that their dog has 6 months versus a year. I'm not going to not tell them the information. The other thing that I remind people, and the survival times in perspective to a pet's life is different than our perspective. Right. So when we say a dog will live 12 to 14 months, for lymphoma, I say, but let's put that into perspective. Without treatment, it's a month.
Yep.
And how long does a dog live? So that, in people, they give 5-year survival times, and we live 70, 80, 90 years. So for a year, for a pet's life, is not insignificant. Never enough if it's your own pet.
Right.
But I do think that it is, you have to put those numbers into perspective.
And are there any numbers out there that are, in general awareness that are not accurate now? Like, what are some of the misconceptions about the more common cancers that we treat that you found that you fight against? And what are the things that you've discovered in your career that really all of us in general practice should know? I mean, the one that comes in my head are mast cell tumors. And I remember what I was taught about mast cell tumors, they're going to have this sort of 3 to 9 month survival rate. And then I got in practice, and I think the only ones I ever euthanized because of the mast cell tumor were ones that came in with very advanced metastases in the chest. But I can think of 2 of those in 20 years. The rest of them all died of other causes.
Yeah, most dogs, with mast cell tumors, which is the most common malignant skin cancer we see, I tell people one size does not fit all. My parents' dog had a very aggressive mast cell tumor, and the dog had a lot of other health issues as well. And they didn't treat it aggressively. And I told Mom, based on the biopsy and the mitotic index and all of this fancy stuff, I said, Mom, we're looking at 3 to 4 months. The dog lived 10 months. And she's like, you're wrong. I was like, yay, I was wrong. So I lived to be wrong. But, there are many mast cell tumors that, and that's the whole point of my cancer awareness program, find them early, cut them off, get clean and wide margins, and they're unlikely to spread. And those dogs can go on and live very long, happy lives and probably have other medical issues that will be their demise, right? So one size does not fit all, but people hear mast cell tumor.
Yeah.
Or, my cousin, Jason and Lainey, their first dog, Sammy had a horrible one of these aggressive, crazy mast cell tumors. Their current dog, Maggie, just had one of the good ones.
Yep.
And we talked, it was like PTSD. Like, for them, it brought back all of the emotions about Sammy.
Yep.
And he got sick on treatment because because he was my cousin's dog, but Maggie's going to be okay. But for them, having to relive Sammy's experience was so emotional. So I think a lot of the times with people, with, pet owners, and you tell them that maybe you tell them their cat has mammary cancer, maybe their mom just had breast cancer. There's so much that, goes into. So I can tell them that cat's going to handle chemo better than a dog. They're thinking about their mom, and so there's so many things that are tied into what we do in helping the pet owner get through it.
That's fascinating. How much of it do you think is the medicine, and how much of it is the management of the personal circumstance and the mental state of the owner then?
I think it's a combination of both of those. And that's why that was something I don't know that my residency prepared me for. It prepared me for the statistics and how to, manage the cases medically. But I'll say managing the client and their expectations, that's something that's come from experience of being in the exam room and wanting to communicate better.
Yeah.
And want to communicate with veterinarians better because, what you said about mast cell tumor, made me a little bit angry. Like, what do you mean that's what we learned? But there's sometimes those are the things you learn. You're like, wait a minute, they're doing much better. So that may shape a veterinarian from not sending me a mast cell tumor that could be like Maggie's and could be really good.
Yeah.
So it's my frustration. And that's why I lectured, let's get out there and give everybody really good information.
Yeah. So what other misconceptions are there that you see that are frustrating that really we need to know?
One of them is dogs with lymphoma still getting started on steroids before they've had all of their diagnostics and sometimes before they've even had a lymph node aspirate.
Yeah.
So they come in with big lymph nodes and they go home with antibiotics in case it's like a tick infection, so doxycycline and prednisone. And then they come back in, so that's one of my frustrations.
What impact in terms of survival time does that decision have?
So 2 negative things. One, we know that, and this is in dogs, not cats, but dogs that are on prednisone before they start their chemotherapy, it makes their lymphoma less responsive to chemotherapy. We don't know by how much time, so I can't say like it knocks 4 months off.
Right.
But we know that there's a chance that it will make their chemo or their lymphoma cells more resistant to chemotherapy.
Yeah.
The other thing is maybe we haven't done all of our diagnostics. So there's a test that helps us pick their chemo, and the one that tells us whether it's B or T cell. If they're on prednisone, so sometimes the vet will aspirate it, send it to the lab, start them on pred, and they come see me and all the lymph nodes are gone. I can't figure out which one it is. And that's the strongest predictor that we have for outcome. And so
that messes with your ability to then have a conversation that's just accurate with the pet owner and manage their expectations.
And unfortunately, I see that at least once a month.
Yeah.
And so it's one of those ones that is worth repeating. And for all the veterinarians out there who are not doing it, thank you. But, on the flip side, if you have a really sick dog that can't breathe because he has huge lymph nodes under his neck, by all means, do your aspirates and start them on steroids. But for that dog that's still eating well, or maybe their appetite's a little bit off, I say, hey, can we give them a different nausea medication to get them through until they come see me over the next couple of days? Because I'll get them in the next couple of days.
Okay. And
sorry.
And no,
that you got me on my soapbox.
No, I'm great. Stay up there. What I'm conscious of is there's a lot of people listening that can't refer to Dr. Sue. Is there a process that you would suggest is a good, what's the benchmark? In terms of the standard of care that a general practitioner, these are the things you really ought to do with lymphoma, and maybe more broadly with cancers as a generalized approach to them? And is it appropriate to say a generalized approach to cancer?
One of the reasons that I lecture is there are many parts of the country where there is not a cancer specialist, or someone would have to drive 6 hours. Like, someone's not driving 6 hours weekly for the CHOP chemotherapy protocol for their dog's lymphoma. I hesitate because some oncologists believe that every cancer patient should be managed by an oncologist and don't like when general practitioners are doing it or being taught how to do it better. I tend to be a little bit more practical.
Yep.
And I think that there are veterinarians who are doing chemotherapy, and so hopefully they're coming to my lectures or reading articles and learning how to, or anybody's lectures, but they're learning how to do it better. Because I think it's very naive to think that cancer specialists are going to be the only one treating cancer. In the US and Canada, there's something like only 400 oncologists. It's crazy. There's not enough of us, and there may be 10 of us clumped in the metro New York area.
Right.
And then you go to other parts of the country. So I do think it is reasonable for general practitioners to treat cancer patients, but let's hope that they're learning about it. They're doing the right chemotherapy safety things for their staff and their clients and themselves, and then getting better at it.
And on the safety issue, we had dinner last night, and you were telling me a story of somebody. What was it?
So one of my nurses, when we started the practice that I was at before this one, so almost 10 years ago, she was a supervisor, smart technician. But she said at the past practice, her boss said, go outside to draw up the chemo and make sure that you're not standing downwind.
Downwind.
I think she was allowed to wear gloves, but no hood, no closed, connection system to decrease exposure.
It's a very natural fume cupboard, right?
Yeah.
Unless you're
crazy,
downwind.
Right? Horrible.
So I'm going to come back to, again, one of the other things that you mentioned was, or we were talking about, was the connection with clients in the exam room. And certainly from my time spent in exam rooms, and I've watched a lot of people doing consults now, what I've noticed is that vets frequently know what's going on with the animal, but struggle to find the right words to communicate that in a way that the owner then takes the action that's in the best interests of the animal. And it's almost never about money from the pet owner's perspective, although it's frequently about money from the veterinarian's perspective. That, to my mind, when you add in the sensitivity and the emotion of dealing with a pet with cancer, that would seem to me to be something that would amplify that effect to make that harder. So the language we've said obviously does have an impact. Do you have any advice for anyone listening about what sort of language, or what language would you use in that moment in the exam room with clients?
For me, two tips that have really helped me in the exam room recently, and I've actually gotten very interested and researched and learned about it. But the two tips that I have is empathetic phrases, where you say, and I now actually write it on the discharges. We're all rooting for Henry. I'm concerned about the X-rays. So it's just where you're part of the team. These are not the results that we were hoping for. So it's not like you're going to be disappointed. This is we're all in this together.
Okay, together, yeah.
Yeah. So I think the empathetic phrases, and when I talk to other veterinarians, I say find one or two empathetic phrases and just incorporate them into your talk. To really drive that home with the owners. And then the other big thing that has helped me in the exam room, especially those initial consults. When I was a resident, we went in, and it's called the shot put method, where you just go in and you give everybody all the information. And I would walk in and I'd say,
show up and throw up.
Yeah, that's great. I love that. Can I take that?
You can.
Okay.
Yeah.
But I would go in and say, I know your dog has lymphoma and you have a lot of questions. I'm going to go through everything, and then you can ask questions. And I would tell them how lymphoma starts, and I would tell them the tests that we do, and then I would tell them the treatment options, and then I tell them the prognosis, and then my nurse would come and give them the estimates typed up for them so they had it.
Right.
With information sheets and a nice package, all this info that they need about chemotherapy. And at the end, I'd be like, do you have any questions? They'd be like, maybe one. No, you went over. They'd look at their list. No, you went over everything.
Yeah.
Now, what I really think is a much better way is it's more of a dialogue.
Yeah.
It's called the Frisbee Method, where you go back and forth. I like the chunk and check, which I think is just a great name too.
Yeah.
I didn't make that one up. But you go in and you give a chunk of information, and then you check with an open-ended question.
Yeah.
Do you have any questions about that? Or what questions do you have? That's going to be better, because you don't want them saying yes or no. So give them a piece of information and then ask them. Give them another piece of information and let them have questions before. Oh, can I give one more?
Yeah, please.
Okay.
It's great. You can give as many more as you like.
I mean, and this is one that scared me when I first started doing it. And I walk in and I say, what do you know about your cat's lymphoma? And they kind of look at me sometimes. They're like, well, that's why I'm here. I'm like, no, I just want to know what have you read online? But what I love about that, sometimes they'll be like, oh, well, my dog had hemangiosarcoma and we euthanized him on the table. Or, my other dog had lymphoma and, lived 2 years and never had a chemotherapy side effect. I'm not afraid of chemo. So by asking that information up front, you get to tailor your talk to their needs.
Right.
And I really like it. But again, at first I was like, oh, do I really want this opportunity to find out what they know?
Yeah.
But it's good.
And if it sounds like there is a war going on outside, it's because we're being buzzed by... Virginia Beach is right next to Oceania Naval Air Station, where they're doing a lot of training exercise with
all the time,
F-18s
day and
just
night. Yeah.
buzzing us nonstop here. Empathy, therefore, sounds like that's what you're getting at there. The ability to understand their position and then empathize and change your approach based on that. I like the Frisbee method. That's quite cool.
Yeah.
That's a cool name as well. So I might use that one. We can swap.
I like show up and throw up. Is that it?
Well, there, you can have that one. I'll use Frisbee. We can reference each other. You work each day, to treat cancers, and I'm really fascinated by your viewpoint of seeing it as a chronic illness, not a death sentence. How do you do that, practically speaking? And then there's a part B to that question, and that is always there's almost this friction between general practice and specialty, where people wonder whether or not they either should refer, or whether or not, you see things that sometimes refer to specialty facilities, and then the animal has an awful lot of treatment, and on occasions they still lose the animal, and you wonder, although magnificent pain management and surgical technique, there's still an impact on that animal's welfare. There's an impact on the client's bank balance, and there are always occasions where you don't get that win. Do you have a criteria for when you think this is a good case and when you think this is not a good case? And how do you approach that as a challenge? That's a long question.
It is, and it's hard because you may have your medical opinion and the owners could have a different opinion. So there are some cases where like this, and I'll be really blunt, like hemangiosarcoma, which I think is a treatable cancer, but it's still a crappy cancer in the sense that, getting to the 1 year survival time like we can with other cancers is much harder. And so they're going to have to go through surgery, and then they're going to have chemotherapy, and the 1 year survival rates are still low.
Can I ask a sidebar on that? And that is the cases where, then you do the ultrasound scan and you find the gigantic mass in the abdomen. Those ones have always turned out to be benign in the biopsies I've done when I've done the surgeries. And it's always the little ones in the spleens that have turned out to be the horrors. Is that...
Yeah, so I actually have a talk on splenic masses that I'm doing while I'm here, but it came from when I changed practices a year and a half ago. The ER doctor saying to me, "Can you do a talk on splenic masses? They're always hemangio." And I'm like, "No, they're not." And so we go through the statistics, but size doesn't matter.
Right.
Size is not, that's one of the myths, that's one of the tips. Size is not going to tell you whether it's benign or malignant.
Right.
In incidental splenic masses, so you're doing an ultrasound for something else and you find a mass in the spleen, those are actually more likely to be benign.
Yeah.
If the dog has a hemoabdomen and no history of trauma, instead of being about a 50% chance of hemangio, it goes up to like 80%.
Okay.
So that's why my ER doctors always think the collapsed dog with the bleeding splenic mass is hemangio because it changes the statistics.
Yeah.
So, but size is not a good predictor. Ultrasound appearance, so I have slides that my husband gave me because he does all the ultrasounds. And I said, I need a hemangioma, the benign one, and hemangiosarcoma. And so he sent me the images. And I go, which one's which? He goes, that's the point, right? And he's like, so I was like, well, I want it to be accurate. He's like, it doesn't matter. But, they were different patients. But
it just isn't. So deal with it.
Yeah. But I did make him look it up.
Sorry, I distracted you from the question, though.
What was the question again?
I think I forgot as well. No, the question was, so part one was, how do you make cancer stop it being the big scary C word and make it a chronic illness? And what practical steps do you do with that? And then how do you determine when an animal is a good candidate and an animal is really not a good candidate?
Most of our patients are good candidates. Some of them just require more work. So like a dog that has a bleeding splenic mass may need a transfusion before surgery, may need other stuff to kind of buff them up to get them through the surgery.
Right.
But cancer tends to be in middle-aged and older dogs. And some of them have concurrent issues, diabetes and, other things. But in general, most of the patients that I see are really good candidates for treatment if the owners are on board and have realistic expectations. The reason that I think that we treat it like, a chronic condition is because, for example, lymphoma, even once they go in remission and they finish chemo, they're likely going to relapse, right? So we're not curing them of their cancer, but can they live longer and live well during their treatment and then after their treatment? And most of my patients, like I said, they're the ones in the waiting room wagging their tail, very happy patients. And so that's why I know that treating is a good option.
I was told I guess when I was an undergraduate 20 years ago by David Argyle, he said, the rule in veterinary medicine is it's not about quantity, it's about quality.
Correct.
Have we moved on from that now? It's 20 years, a lot of things have changed in medicine. Are we at the point where we can say actually we can get both, or is it still too vague as to how this disease operates to be able to say something like that?
I think it will always be about quality of life. We want them to be tolerating treatment very well. And I feel now we have better preventative medications, better nausea medications. I'm way more preventative, and I teach veterinarians that when I talk about how we give chemotherapy to be very proactive with nausea medications and diarrhea medications and things like that. So they're getting less side effects, or if they get them, we can really jump on top of them.
Yeah.
So I think that has made their quality of life improved during treatment. The quantity, some cancers we're doing a better job now, and some, there's some exciting new treatments for lymphoma out there now. But that is one of the frustrating parts is, you're making me pause. I'm thinking like in the last 20 years, are there cancers that we're doing a much better job? I think we're doing a better job, not just with the time, but with the quality of time that the pet has, not the quantity maybe.
Okay. And now I want to just switch gears slightly here and talk about the role of nutrition. It's something that certainly I've been becoming more interested in over the last few years. And certainly from the human side of things, you know, a lot of the old diseases we used to see in veterinary medicine and in human medicine or in human healthcare have gone, things like rickets and nutritional deficiencies, and we've replaced them with diseases caused by an excess of carbohydrates and fats, or the wrong kinds of fats in our diets. Are we seeing that? I mean, it seems like we're seeing that same trend, certainly in terms of obesity and in the exam room. And some of the interesting research that has come out on the role of fat as a, you know, and this is very noddy general practitioner understanding of this, so forgive my brain if this is awful, but almost acting as an amplifier for inflammation and a force multiplier, and that how is that impacting on, or these lifestyle choices and the nutritional choices we make for our pets now, is that having an impact on the development, on the incidence of cancers? You know, there's a lot of people on the human side think that we're seeing cancers in younger and younger people because of nutritional choices. We're seeing effects like that in human medicine, and is there any advice that you think we should be giving pet owners in regards? So I'm thinking about preventive treatments now.
I don't think it's so interesting. I don't know that we have the studies to show that there's a great Labrador study that showed that leaner Labradors lived 2 years, but they didn't look at other diseases like diabetes and cancer and things like that. Yep. So
it's too broad
Right. I think we have to extrapolate that. We know in people, the two lifestyle choices are diets that are low in fruits and vegetables, and obesity are linked to cancer. So for me, I think that's a reasonable, leap to our patients in saying leaner pets are probably going to be at lower risk for cancer, though there aren't great studies to look at that.
Right.
And, diets and fruits and vegetables, I do recommend, adding, except for the ones that they're not supposed to have, like onions and things like that. But, having our pet owners, add vegetables. There's limited studies. There's a great one in Scotties with bladder cancer.
Right. That
got more vegetables. It was usually carrots because that's, I guess, what people were getting. It was where they looked back, a retrospective study. But, those that got fruits and vegetables more than a couple of times a week had lower incidence of bladder cancer. So again, I think there are some studies coming out there, but they're not as good as they are in people. But I think it's a reasonable thing to say, we don't want overweight pets, and let's think about what we're putting in them, whether, good foods, good diets. Not everybody can home cook,
Right,
but I think that there are other
most of us humans don't manage to home cook for ourselves. I have
clients that do home cook cancer diets for their patients, for their pets, and I'm like, listen, there's no judgment here. I can barely get a home cooked meal on the table for my 2 boys and my husband, so I'm not home cooking for my dog. But luckily, there's some good, commercial diets that are, that deal with a lot of the issues in some of the other commercial diets. Okay. I'll leave it like that.
All right. Now, I have a couple of questions from listeners.
Okay.
The first one is from I think a mutual friend, Bill Schroeder. Mm-hmm. And Bill asks, are there any misconceptions pet owners have when they learn when their pet has developed cancer?
I think we talked about that. I mean, I think the biggest one for pet owners is my pet going to die? Like now, like how long are they going to live? And then if I decide to treat, will they be sick the entire time? And they won't. But I think, so when I tell people 80% of dogs and cats have no side effects to chemo. And when they do, it's usually mild and it only lasts a couple days. And we have great medications to support them through it.
Right.
They're not going to be in the hospital, sick from chemotherapy side effects. Very uncommon in dogs and cats. And
do you achieve that 80% by medicating them and managing their symptoms proactively, or is that 80% regardless of what you do?
It's a great, it's actually a hard number to find the statistics where that came from, because when I write a journal, but most oncologists say that, and there isn't, I don't know if it's like 8 glasses of water, but I mean, in my experience, it's about 80%. But I do think it is because we need to be proactive with their medications. And there's simple things like giving nausea medication with treatment. having the owners have it on hand at home so they're not waiting 5 hours after a pet vomits to go get it. Like, oh, I have the nausea medication. I'm going to give it right now and I'm going to jump on it. So I think it's probably because we're so proactive, but dogs and cats handle chemo better than people. They just do. And cats better than dogs. So some of it is species related and some of it is how we approach their treatment and their dosages.
Okay. And Jen Wardlaw asks, how do you cope with die-off as an oncologist? And I think that's more about your dealing with that, because it's a mental, we all have those, I've observed this rather chilling phenomenon, which vets in the UK call the Christmas clear out, which is sort of gallows humor, I think, where there are certain times of the year vets become a bit disposable, and 3 euthanasias in a row is a pretty gut-wrenching thing to have to do. How do you cope with that? Are you coping with that, or do you see the last few days, or is that done with the general practice? Do you have any ways of keeping happy through that? I'm
surprised how many of my clients want to come to me for the euthanasia because they feel like we understand them. We know what the pet's treatment has been like, whether it's been over 3 months or 2 years. And a lot of the times, they choose to be with us because they've bonded with the oncology team and they've been seeing us. And my nurses are phenomenal. It's not just me. It's I couldn't do what I do without them, and they support them through so much. I mean, they're like counselors half the time. Right. So for me, what helps me get through, because some of those are heart-wrenching and I'm crying with the owners and I'm going to, when I walk out of the room, I'm like, I can't do this. But then I get the card from them and they tell me like, thank you for the last year and a half that we had. Yeah. And because of you, we had more summers, up in Vermont or, or things like that. And it's like, I know that really sad moment that we've had so many good times that the family had with their pet. Yep. And that's how I get through it, is I focus on the positive. But it hurts during those times, for sure.
No, that's a very inspiring answer. All right, let's change pace and
okay, stop making me cry.
So I'm going to move into the more quick fire questions. Good. Now. I know I'm going to be respectful of your time because you are speaking in the not too distant future. Yep. So here we go, and you can give long answers or short answers. Okay. I'll try to be short. They're short questions. Okay. So what's the thing you do? What does Dr. Sue do? I mean, probably the clue's in the name here. This could be the stupidest question of all time. But what's the thing that you do better than anyone else? What's your superpower?
Oh no! What is my superpower? I don't know that it's a superpower, but I just try to be positive and I try to be kind to the people around me and not be a source of negative energy.
And what's your kryptonite or your anti-superpower?
I'm too sensitive and I care what people think.
What do you think is done? I'm going to leave this open, right? But what's done well in veterinary medicine?
I think we are good advocates for the pet, and that's really hard because they can't always tell us what's wrong. And I think that's it's like pediatrics, right? Yeah. So the client, quote unquote, is the parent. I take my son in and he, I can't figure out, the pediatrician's like, he has an ear infection. Like, oh, thank God. So I think in general, veterinarians are really good advocates for the pet and really good at overall pet health. On a day-to-day basis. Now,
I've had some really funny answers to this question, so no pressure on you all. And not always funny, like for good reasons. In fact, usually the next two are some of my favorite ones. So what's the best piece of advice you've ever given or received?
Relax more.
Did you give that or did you receive that advice?
I think probably both, but probably to receive it. I think that I am a very stressed person. I'm a very high intensity person, and I think that it can be too much. So I think it's for me, it's been the continual effort to try to. We talked about the work-life balance, and how hard that is being a working mom and my clinics and then all the Dr. Sue stuff that I do. So I think it's just trying to relax and enjoy the everyday things more and not get caught up in it.
And so do you have any specific things that you do to relax that you found to be highly beneficial? Because I say you're doing a lot of stuff. Again, I want to be respectful of your time, so I might leave it for a round two if people want it to ask you about the balance between work life, being being a mom and being a successful business lady as well. We won't go there now because that's another huge topic. But what are your tactics to have that?
The easy thing for me, which to answer that I've just started doing about 3-4 years ago, is I work out most days. Whether it's just getting at a short workout, I get up. I'm not a morning person, but I get up every morning before work and I work out every day in the weekends, and it clears my head. And if I don't do it, I feel more stress. So for me, exercise and movement, even if it means less sleep or sacrificing something else, has been so important for my mental health.
Do you have a time of day, like, because you've got two boys who are a little older than my daughter, and I know that one of the challenges I have is as soon as my daughter's awake, then there's no chance for exercise.
I get up early in the morning.
You get up early? What time do you get up?
A little before 6. It's not crazy.
Yeah.
It's not crazy, but I get to work a little bit later and I stay work a little bit later. But I'm up between 5:30 and 6. But if I don't get it done in the morning, it's not going to happen. So you just...
All right. So part 2 of the question was, what's the worst? This is usually the funny one. So what's the worst piece of advice you've ever given or received?
Relax more? No. Don't worry about your presentations. Come out and hang out with us. No.
Quote unquote. Apparently something I said last night. For taking a dog
we'll see how my talks
dinner.
go today. My worst piece of advice: become a surgeon. No. You can be a surgeon too. Probably. I mean, some of it would be a long answer. It has to do with like working with toxic people, but you can give a long answer. No, I mean, I think some of it is just, being that kept me in an environment that wasn't good for my team's health and my own health. And not just our health, but it was a toxic work environment, and it's like how to change that situation. And so sometimes I think you listen to the people around you that this will be the right thing. And I'm not a quitter, but for me, I didn't quit, but I changed jobs to find a better place. And now, so I think that can be, sometimes when you're stuck in a bad situation, whether it's personal or professional, you get advice during it, and it may not be one quote, but that just, you look back and you say, oh, I should have changed things sooner, or things like that. So I think that's where the bad advice for me has been, where I know I needed a change, but I didn't know I needed a change.
Okay. Life has that way, doesn't it? What books, and I'm thinking more from a business development or personal development point of view here. What books have you read or are you reading that have been really influential on your career and development?
So one of the books that I've read recently that I love is Made to Stick, which is about making ideas sticky and creating hooks like Velcro. So I love that because it's what I'm trying to do in the lecture hall, right? We're trying to get people to have practical tips that they can go back to the clinic and be better clinicians, but you're also doing it in the exam room, right? How am I going to make this idea sticky to the owner that they can go home and tell their spouse about chemo? So I love the ideas. That's been one of my favorite books recently, is Made to Stick. Our mutual friend, Dr. Andy Rourke, recommended Never Eat Alone.
Yeah.
And that's about, and what I love about that, it's not only about networking, but it's about building relationships. You want to work with people like, and trust. And so that's one thing that's been really one of my favorite parts about coming to these conferences, is meeting new colleagues and connecting with people. And then we help each other and we build each other up. And we're all going to succeed if we do that.
It is amazing how many people that I have met through the CVC and the other conferences I've spoken at, and the journeys then that you go on with the people that you would never have thought possible.
Yeah. And to sort of go back to the bad advice thing, I try to surround myself with the people that we will build each other up, because there are unfortunately too many people in our profession and in this world that will push us down. And that's, where we talk about the toxic work environment and things like that, where they just squish your ideas, squish your aspirations, and that's not where any of us should be.
Here. What's the most controversial or interesting thing about Dr. Sue that people don't know that would amaze them, amuse them, or shock them that you're willing to say on
most controversial?
On record?
Do you have any ideas?
No.
I was
no.
Dude,
I'm not fishing there, by the way.
No.
But it sounds like there's stories.
There's always good stories, but I don't know if off the cuff I can think of a good one. It's not controversial. If I could do one thing more, it would sleep. I feel so sleep deprived most of the time, but that's not controversial. But I love to sleep. I could sleep 12 hours a day. But for some reason I'm, getting by on 5, maybe 6. That's not a good answer. Sorry.
That's okay.
Now I want to know your answer for that one.
Oh God! No, there's no way that I will say that on record. Certainly not my own podcast. That might be suicide. So if you could send, you're a big social media user. You're the first guest on the show that is a big social media user. So if you could send one tweet to the world, so it's got to be under 140 characters, what would it say? Everybody on Twitter would just get that like some magic smartphone. What would it say?
Cancer in pets is not a death sentence. Early detection saves lives. # why wait aspirate.
I absolutely love that hashtag, and there's no way that I can conduct an interview without getting you to expand upon that, because I get it, but say more about your See Something, Do Something program.
So it's an early detection program for lumps and bumps in dogs and cats. That the story behind it is, again, one of my biggest failures, which was my head nurse's dog, Smokey, had a bunch of benign lipomas, so those benign fatty tumors that I had aspirated over the years. She found another one, and we just got complacent. And it turned out to be a 7-centimeter soft tissue sarcoma. He's Addisonian. He had kidney disease, had an arrhythmia. So we had a lot of concurrent, conditions that we talked about, but it required a big surgery and a big flap. And I realized I missed the boat in one of my favorite patients. And I realized there's no good guidelines for lumps and bumps. So I just started this program. I got a bunch of colleagues to give me their input. And now it's a joint program that I'm working on to roll out through the VCA hospitals. But I lecture everywhere about it. But it's simple. The mass is the size of a pea, which is 1 centimeter, and has been there a month. So that's to see something. We want to do something. We want to go to our veterinarian and ask for an aspirate. And I'm strongly encouraging veterinarians to do those aspirates. And through social media, I had a woman in England said, through your tweets, I have gone to my veterinarian and they found a mast cell tumor in her yellow lab. So even through the power, that's what I love about social media. And that's why I spend so much time on it, is I'm reaching people in Australia and England and within the States that are being empowered to go to their vet and find lumps and bumps when they're smaller and can be cured with surgery alone.
And so this is a campaign that who's the primary target of the campaign? Is the pet owner or the veterinarian?
Yes. So there's 2 target audiences. And so one is the veterinarian and the veterinary team. So because if a pet owner comes to you and says, I want an aspirate, I found this lump or bump, Dr. Sue said, see something, do something.
Yep.
And you go, nah, it doesn't look like cancer. It doesn't feel like cancer. I can't look at a mass. You can't look at a mass and know what it is.
Yeah.
And lipomas and mast cell tumors can look exactly alike. And I'm still fooled because we can't. So I want veterinarians to do the aspirates, and I want pet owners to know when they go to the veterinarian that you need to do the aspirate. So they'll be like, you're going to say, I'd like to do an aspirate. They're like, of course. Just like, I want to check for heartworm. I'm going to run a test.
Right.
Of course. Right. So everybody 2 target audiences.
And so let's see if we can lay one thing to bed here in the podcast as well. And that is, what is the right way to take an aspirate? Everyone's got an opinion on this.
There's no right or wrong way.
Or the best, most effective.
Best way. I like what's called the fenestration method, where you take the needle without the syringe attached, put it in the mass, poke it around, and then you attach the needle to syringe over your slide in case a little comes out when you make the connection, and make your smears. The other method is the aspiration, where you keep the needle and syringe together, insert in the mass, and draw back. That's better for like fluid-filled lumps and bumps, but I find the one where you're just using a needle, I usually use a 20 gauge needle, that I get very good samples. But the answer is you got to know how to do both. And we talked about this early, like my son and his basketball. Practice. They're very easy to do. And if I can do them, remember, I couldn't be a surgeon, but I can do aspirates. Yeah. If I can do it, you can do it.
And what are the cancers that every generalist needs to know how to identify under microscopy, or should they just be sending them off to the laboratory?
So for the program, we are advocating that the samples have to go to the lab, because I'm not a cytologist and I miss stuff that the cytologist, but in my lectures, we go through the different categories. So I think you should be able to find a mast cell tumor, but sometimes they're hard to identify because they don't have the granules or things like that. But you should be able to tell lymphoma, mast cell tumors. Soft tissue sarcomas are very distinguishable from other ones, and carcinoma. So I think if you can at least know the three categories, you'll be ahead of the game. But do not aspirate because you don't want to look at the cytology.
Okay. And i.e.
send it to the lab. Yeah, right.
Just do it.
And the reason for the program, we said, your vet will send the samples to the lab, is to take away that responsibility for the veterinarian to make a diagnosis right away. I'm a geek with cytology. I really like it, but you don't have to like cytology to do aspirates.
Right. You can always use your support services to get that information. I think it's a great program. Certainly we use it in my hospital in the UK, and where can listeners find out more about that program and more about you if they want to follow you? Where's the best place to go?
I think the easiest way is my website, drsuecancervet.com. But I spend most of my social media time on Facebook, Dr. Sue Cancer Vet, through Facebook. And every day I usually post a story. Now I'm vlogging for some strange reason. And I say that because it's such a time suck, like podcasting.
Right.
But, and I share stories of loss, but a lot of stories of hope and successes and anniversaries and milestones that we hit with our patients, and, try to educate veterinarians and pet owners about the successes that we have. And it's a really fun community. And my husband calls my Facebook page my boyfriend, and I see my boyfriend every day, and I spend a lot of time. But again, it's like that client in England who found her dog's mast cell tumor because of me. So I just feel like it's a really fun way to share the knowledge.
It's a great Facebook page to visit, and the content is very good, and it's uplifting and it's educational. So that's fantastic. Dr. Sue, thank you so much for your time and for your energy and for your talks. And if you get the chance to go see Dr. Sue speak, please do that. You got to publish them online if you've not already, and because it's great information. And it's what she's doing is making a topic that a lot of us, and I would put myself in that bracket as well, as general practitioners, have blocks about the whole area of cancer care and beliefs that maybe aren't true. And Dr. Sue's challenging them and taking complex material, making it simple, making it digestible. So definitely check that out. Dr. Sue, thank you so much for your time. It was great talking to you. I hope if you guys out there like this,